Hi friends, good evening. I'm Dr. Ashutosh Gupta, and this is our series of an IUGR in which the plausible and the probable reasons for an intrauterine growth restriction, which we usually call as an IUGR, would lie with the classical uteroplacental insufficiency. So, meaning thereby that the uterine arteries are not behaving, and therefore the blood supply to the uterus is not good, and therefore the umbilical artery flows are also not that great, and therefore we can have growth restriction. This is a classical uteroplacental insufficiency. The earlier video that we have posted, in which we have tried to explain that the maternal conditions, like celiac disease or inflammatory bowel disease, IBD, or probably a autoimmune disease or a nephropathy can also lead to this severe IUGR. Now, in this video, we are talking about a DADC twin and a very different perspective in which we had one baby was having an IUGR. So growth restriction can happen because of the unequal placental share. So one of the baby is growing big at the expense of the smaller one. And but let us go through these slides and through these videos, and then probably we'll try to understand what exactly is happening to these DADC twins. So look closely. This is at 28 weeks. Okay, we are doing the Doppler, and then we have identified that the umbilical artery Dopplers in this baby is normal. The other baby is having an absent end-diastolic. So absent end-diastolic flow is on in all the quadrants across. And then we did the biometry, and we identified that the bigger baby is having 1.3 kg weight, and then the baby with an absent is 1.1 kg. And then we try to look around what exactly is going on. So what we've identified is that it is a sort of a marginal or a velamentous cord insertion of the umbilical cord into the placenta. Then we are doing this at 30 weeks. So this is the same bigger baby within good amniotic fluid, good umbilical artery flows, and reversal and the smaller one. So this is a reversed end-diastolic flow. And then we did the biometry, and we identified that 1.3 kg has gone to 1.6, and 1.1 kg baby has gone to 1.3, right? And we are just trying to see. So this is the DADC twin, and we are just trying to look around what exactly is happening. And so this is that umbilical cord, and then the umbilical cord insertion into the margin is the reason for it. So having an absent end-diastolic flow at 28 weeks and the baby's weight is 1.1 kg. So this is there would be a lot of things to talk about, and whether we would deliver the baby with 1.1 to one of the baby. So probably whether we are going to have that premature delivery to salvage the smaller one. So so that was not the correct way of seeing this whole scenario. But as we continued it for 2 more weeks, and then we identified that it was a reversal. But in the meantime, what has happened is this: that the bigger one is 1.6, so meaning thereby that it is a good weight, and then the smaller one has also grown from 1.1 to 1.3. So by the grace of God, there was some sort of the weight gain to the baby also. And then with the reverse endostolic flow, we we thought that it is worth taking that risk of taking these babies out. And so I've always believed that the IUGR babies with an abnormal Dopplers would absolutely do good, right? So it was an absent endosolic for a pretty long time, and then we're having a reversal at the moment. So I was of this belief that probably the baby which is having an abnormal Doppler would grow better and mature, because systems would grow better, and they would have a sort of not a abnormal sort of an outcome. So we did the cesarean. We took the baby out. The weight was almost in the same range. It was 1.3 and 1.7. But the good part is there that both the babies had a good cry, and first baby was absolutely normal, and the smaller one baby had gone to a CPAP, right? But by the day 2.5 or day 3, the baby was in a room air, and so there was no need for a ventilator, and then the babies are doing good, right? Even though the baby would need some NICU, the admissions and follow up and all those stuff, but probably we were able to salvage this pregnancy. So meaning thereby that IUGR can happen because of a lot of interplay. It could be uteroplacental, could be maternal conditions, and could be the placenta could be at fault, right? So that is how the things are. Thank you very much for your patience.